What are the reasons? Okay, dual blood supply. What are the arterial blood supply of the lungs? Pulmonary artery, which comes from? Saan galing ang pulmonary artery? From the right? Right ventricle, and then bronchial artery, which is? Branch of the aorta. Aside from having a dual circulation, what is the other reason why the lungs will develop red infarction? In solid organs, what type of infarction will develop? White infarction. So, the lungs are soft, that is why they will also develop red infarction. So, on scanning objective view, that is the infarcted area, we are able to see alveolar spaces which are already occupied by red blood cells, indicating that the blood vessels have already ruptured and caused the extravasation of red blood cells into the alveolar spaces. If an organ develops infarction, what will happen to the cells of that organ? If an organ develops infarction, what will happen to the cells of that organ? Okay, the tissues, the cells of that organ will undergo necrosis. Here, we are seeing the remnants of the alveolar wall. Notice that many of the cells do not anymore display nuclei, so indicating that they are already dead. So that's the portion showing us necrosis, which is secondary to infarction. So that is the abnormality which you should be able to identify for this slide. Acute infarction. Sorry. Now, our next slide is labeled as lipid aspiration pneumonia. Lipid aspiration pneumonia. Being labeled as such, we should be able to see lipid particles in order to come up with that diagnosis. So, the abnormality will be seen by examining the alveolar spaces. So, normally, the alveolar spaces should be patent. However, in this lung tissue, we are able to see that is one alveolus, that is another alveolus. Let us zoom in to the two pointed alveoli. Now, the pointed alveoli are not anymore patent. Their lumina is filled already with lipid droplets. Those are the lipid droplets. So that is the abnormal portion of this slide, which you should be able to identify in order to come up with the diagnosis of lipid aspiration pneumonia. Now, when you aspirate something into the lungs, most of the time, that aspirate will become contaminated with the normal microbial flora of the oral cavity. Okay? And then because our mouth contains millions of microorganisms, these microorganisms are most of the time harmless in the oral cavity. However, when they reach the tissues of the respiratory tract, they will become pathogens. That is why, aside from the presence of the lipid droplets, we will be able to see also white blood cell infiltrates, indicating that the tissues of the lungs are already infected by the microorganisms which are present in the oral cavity, and which were also aspirated together with the lipid materials. Okay? If that portion of the slide is shown in the practical exam, what should be the type of inflammation present, acute or chronic? How will you describe the shape of the nucleus of the cells that we are seeing? Segmented or round? Round, so that they are collectively classified as mononuclear inflammatory cells, so that that inflammation is acute or chronic? Chronic. So majority of the inflammatory cells are mononuclear inflammatory cells. Notice the large volume of cytoplasm present in those inflammatory cells. Because of their large volume of cytoplasm, are they the macrophages or the lymphocytes? Okay, they are the macrophages. So in the event that foreign materials gain entry into the alveolar spaces, the first WBC that will be sent by our immune system, because they are already present in the lungs, are the alveolar macrophages. What is the other name for the alveolar macrophages? Dust cells. Okay, that should be the abnormality that you should be able to identify for this slide with the diagnosis of lipid aspiration pneumonia. Our next slide is already familiar to you. You have seen this already. Okay, the diagnosis is chronic passive congestion. How will you call those pointed cells? What? Heart failure cells or hemosiderin-laden macrophages. What is the source of hemosiderin here? Those cells are macrophages which have engulfed hemosiderin pigments. Saan galing ang hemosiderin dyan? Galing sa red blood cells. Saan galing ang red blood cells? What is the major cause of congestion, passive congestion of the lungs? Why are they called heart failure cells? Left-sided or right-sided heart failure? Left-sided heart failure. Now, when the left ventricle develops failure to perform its function, what will happen to the chamber of the left ventricle? What will happen to the output of the left ventricle? Increased or decreased? Decreased, so that some volume of blood will remain in the chamber of the left ventricle. Eventually, there is gradual accumulation of that residual volume of blood inside the left ventricle when the left ventricular chamber will not be anymore capable of holding that volume. Where will the excess volume of blood go? Back to the left atrium, and then from the left atrium there will be backflow to pulmonary veins, and then eventually to the vasculature of the lungs, and then magkakaroon ng increased hydrostatic pressure in the blood vessels of the lungs. If there is increased hydrostatic pressure developing in the pulmonary capillaries, what event will develop first? Secondary to that, increased hydrostatic pressure, which will cause the difficulty of breathing of the patient. Very good. Because of the increased hydrostatic pressure, pulmonary edema will develop. In pulmonary edema, we will be able to see edema fluid occupying the alveolar spaces. Kaya mahirapan maghinga ang pasyente. Now, if that condition is left untreated, and then the patient survives, and then mayroon pa ring passive congestion sa pulmonary blood vessels, eventually, the small blood vessels, the capillaries will rupture. So that the red blood cells will be released into the alveolar spaces. So, because the red cells are not normally present in the alveolar spaces, they will become engulfed by the macrophages. And then from the hemoglobin of the engulfed red blood cell, hemosiderin will be produced from the degradation of hemoglobin. So that's the appearance of the hemosiderin-laden macrophages. Okay? That is how extravasated red blood cells will look like. So, dito may bagong nag-rupture na naman na blood vessels. So, kaya intact pa yung mga red blood cells. They are not yet phagocytosed by the macrophages. Okay. Pulmonary embolism. Okay, our next slide is labeled as chronic pulmonary embolism. That is the abnormality that you should be able to see for this slide. So, judging the diameter and the thinness of the wall of that vessel, it should be classified as a vein or an artery. Sino magsabi na vein yan? How about artery? What blood vessel will serve as the most common cause of a pulmonary embolus? Veins. Particularly what veins? Okay, the leg veins. So most of the time, especially if there is immotility, the thrombus will develop first at the lower extremities and the veins of the lower extremities. And then when that thrombus becomes detached, eventually it will circulate to larger caliber blood vessels. Pagdating sa heart, it will not cause any obstruction in the chambers of the heart because the chambers will have large diameters. The problem will come pagdating ng embolus to the pulmonary arteries or veins? To the pulmonary arteries. So, kasi paliit ng paliit ang diameter ng pulmonary capillaries, ang arteries hanggang sa maging capillaries. That is why there will now be a possibility for that thrombus to become large and cause obstruction in the pulmonary arteries. Will there be a possibility of development of pulmonary embolism in the pulmonary arteries? Pulmonary arteries pala yan. Pulmonary veins. Okay, that will be your assignment. How will we be able to know that material is not a thrombus. And it is actually an embolus. Ano? Okay, it is not directly related or it is not attached to the vessel wall. So as you can notice, we can clearly delineate that material from the surrounding blood vessel wall. Okay. Okay, you have already seen this slide in the first grading period. This slide is diagnosed as sarcoidosis. What type of inflammation is seen in sarcoidosis? What type of inflammation will develop in sarcoidosis? Ano? What type of inflammation? Granulomatous inflammation. Okay? Granulomatous inflammation is characterized by the infiltration of what cells? What is the characteristic leukocytic infiltrate in a granulomatous inflammation? Ano? No? You may have a granulomatous inflammation even if the giant cells are absent. The epithelioid macrophages or the activated macrophages, and then they should be the lymphocytes and then the inflammatory giant cells. How will you differentiate the granulomatous inflammation in sarcoidosis from that of tuberculosis? The absence of caseous necrosis in sarcoidosis. And then aside from that, the size of the inflammation in sarcoidosis is much smaller than that of tuberculosis. So in one field, you will be able to see multiple foci of granulomatous inflammation in the lung tissue. Okay, that should be it for sarcoidosis. Our next slide is hyaline membrane disease. What should be the identifying microscopic feature of hyaline membrane disease? Ano? Tinawag siyang hyaline membrane disease because of the characteristic microscopic appearance. Okay, the presence of pink hyaline materials lining the alveolar spaces. What problem will develop to the owner of that lung? Ano? Difficulty of breathing. What will happen to the degree of oxygenation of the blood? Decrease because of the increased thickness now of the wall that the gases will have to traverse. So, kaya magkakaroon ng hypoxia and then difficulty of breathing. So, there are two types of hyaline membrane disease. The one that will develop in neonates and then the one in adults, ARDS. What is the cause of hyaline membrane disease in the neonates? Ano? Okay, deficiency in surfactant. What is the most common cause of surfactant deficiency? Okay, prematurity. So, that is why, pagdating ninyo ng OB/GYN, pag nagkaroon ng preterm labor, binibigyan ng steroids yung mother to stimulate the production of surfactant. So, because surfactant will only begin to be produced at the 36th to 37th month of gestation. So the alveolar wall will become thickened secondary to the presence of the hyaline materials. In adult, there are several causes of acute respiratory distress syndrome which may also present with that type of morphologic abnormality. So, what is the mechanism behind the development of hyaline membrane in adult respiratory distress syndrome? Ano? Okay. So, because of that, what materials will accumulate at the wall of the alveolar spaces? Ano? Necrotized epithelial cells, what else? Proteins coming from the blood. Very good. Because of increased vascular permeability. So that's the appearance of hyaline membrane also in adult acute respiratory distress syndrome. So the alveolar spaces will become collapsed. That is why we are not seeing the usual number of the patent alveolar spaces. Ito, mga collapse na yan ng mga alveoli. So we are seeing the epithelial cells which are in close contact with each other because of the collapse of the alveolar spaces. So however, in order to come up with the diagnosis of hyaline membrane disease, that should be shown in the practical exam. Okay. Next slide is 143, silicosis. Mag-jump na lang tayo kaya wala dito silicosis. Next slide is asbestosis. Now, what are the abnormalities which you should be able to identify for this disease, asbestosis? Aside from the presence of asbestos bodies, which is very obvious, presence of the carbon pigments in the interstitium. How will you describe now the alveolar spaces? Are they patent or not? No, because there are elements occupying the alveolar spaces. Let us zoom into the pointed portion. Okay, what cells are those? Small nucleus with large volume of cytoplasm. Round nucleus. Asbestos is a normal part of the lungs or not? Not. And because asbestos particles are not normal components of the lungs, when they enter the lungs, what is the first leukocyte that will encounter them? So that those cells should be the alveolar macrophages. And then, how will you call that pointed cell? Those pointed cells. Asbestos particles are not normal components of the lungs. So that when the macrophages coalesce with each other in order to limit the spread of asbestos particles, they will produce giant cells. How will you call those giant cells now? The foreign body giant cells. In comparison with what type of giant cells that will develop in tuberculosis? Langhans type. And then, the specific diagnosis of asbestosis can be established by identifying that pointed particle. Parang dumbbell. That's the asbestos body. Okay? Okay, those are asbestos bodies. So they are already engulfed by the alveolar macrophages. Okay, this slide is diagnosed as silicosis. However, will we be able to differentiate it from anthracosis? Ano bang definition ng anthracosis? What will accumulate in the lungs in anthracosis? Carbon pigments. What will engulf the carbon pigments in anthracosis? Ano? The dust cells again. How about in silicosis? What will engulf the silica particles? What is the most efficient phagocytic cell in our body? The macrophages. So, ayan sila, ang mga silica particles which are already in the cytoplasm of the alveolar macrophages. Kaya pabilog or pa-oval ang shape ng mga black pigments. So, by light microscopy, we will not be able to differentiate that black carbon particles in silicosis from the black carbon particles in anthracosis. So, they will have a similar appearance unless we specifically identify the materials present in the alveolar macrophages, if they are carbon pigments or silica particles. By the way, let us go back to the previous slide, asbestosis. What are the two types of malignancies that may develop from chronic exposure to asbestos? Ano? And mesothelioma and lung carcinoma. Our next slide, number 136, is diagnosed as bronchiectasis. The problem in bronchiectasis is in what component of the lungs or the respiratory tract? Ano? Okay, in the bronchi. What will happen to the bronchi in bronchiectasis? They will become permanently dilated. There will also be tissue destruction. And then when there is chronic tissue destruction, what will replace the dead tissues? That is the abnormality that you should be able to identify in order to come up with the diagnosis of bronchiectasis, which results from chronic inflammation. What are the microscopic features of chronic inflammation? Mononuclear infiltration, which we are able to see in those pointed areas. Let us zoom in. Okay, mononuclear cells, they should be the lymphocytes and the macrophages. Aside from mononuclear infiltrations, what are the other features? Microscopic features of chronic inflammation. Because of chronic exposure to the causative agent, there is also tissue damage. And then whenever damage occurs, what will be the response of our organs? Healing, repair, which will come in the form of repair. So, what are the two microscopic evidences of repair? Fibrosis and angiogenesis. Very good. That is why, reddish, yung area na yan, because of the presence of the newly formed blood vessels via the process of, what is the specific name for new blood vessel formation? Ano? Angiogenesis. And then, these are the alveolar walls. The alveoli should have in their wall smooth muscles. And then, their epithelium will range from stratified columnar, simple columnar to cuboidal to pseudostratified columnar epithelium. Here, the epithelia that we are seeing are almost all cuboidal. So, natanggal na yung regular respiratory epithelium, napalitan na ng cuboidal epithelium. And then the wall of the alveoli do not anymore contain smooth muscle fibers. So, the smooth muscle fibers were already destroyed and they are already replaced by fibrous connective tissue. So, we are seeing here all the evidences of chronic inflammatory process. So, tissue destruction evidenced by the replacement of the usual tissues by fibrosis. And then we are also seeing angiogenesis. There are numerous thin-walled blood vessels. Okay, the problem with bronchiectasis is that the bronchi and the bronchioles will become permanently dilated. Okay, here, evidence of an abnormality here. This is a large caliber airway already. Okay, that should be a bronchus because of the presence of that tissue. How will you call that tissue? Hyaline cartilage. And then the wall, madami tayong makikitang black dots. Those are the mononuclear inflammatory cells. So indicating that the bronchi are also chronically inflamed. Mayroon ding evidence of tissue destruction here because in that portion of the wall of the bronchus, we are able to see smooth muscle fibers. In other portions, okay, wala na ang smooth muscle fibers in that portion. So, dyan din. So, the smooth muscle fibers are already replaced by, how will you call that pointed tissue? Fibrous connective tissue or fibrosis. Yan na ngayon ang microscopic appearance ng scar. So, supposedly, there should be smooth muscle fibers and mucous glands in that portion of the bronchial wall. They are already replaced by chronic inflammation and fibrosis. So, most likely, in the practical exam, that should be the portion of the slide that will be shown. So, showing us dilated airways with chronically inflamed and fibrous wall. Next slide, you have already also seen this slide. That should be the abnormality that you should be able to identify. That's an airway. Based on its histology, it should be classified as a bronchus or a bronchiole. A bronchus or a bronchiole? Why? Because of the absence of the hyaline cartilage. Now, who among you here are asthmatics? What is the problem of patients with asthma? What is their major complaint? Dyspnea or difficulty of breathing. What is the cause? What are the causes of difficulty of breathing in asthma? One is bronchoconstriction or contraction of the smooth muscle fibers in the wall of the bronchioles. Not only in the bronchioles but also in the bronchi. But the difficulty of breathing will come most of the time from the contraction of the smooth muscle fibers in the bronchioles. Why not in the bronchi? Ano? May smooth muscles pa rin ng bronchi. Because of the absence of the hyaline cartilage in the wall of the bronchi. Maski na mag-contract ang bronchi, ang bronchus, the lumen will remain patent because the patency will be maintained by the hyaline cartilage. The problem will come in the bronchioles. Walang smooth muscle fibers pag walang cartilage, pag mag-contract ang smooth muscle fibers, the lumen will become markedly decreased in diameter. Aside from that, how will you call that material occupying the lumen? Mucus. And then how will you describe the thickness of the wall of the bronchioles? Increased thickness or decreased thickness? Okay, mas klaro ang creased lang. Increased or decreased? Increased. What is the cause of the increased thickness? What type of hypersensitivity reaction is involved in asthma? Type 1, which is also called as hypersensitivity, immediate hypersensitivity reaction. What type of antibody is involved? IgE. So once an allergen binds to IgE, antibody, in the surface of what cells? Mast cells. What will be the response of the mast cells? Degranulation. So there are several classes of chemical mediators that will be released. The most important is histamine. Histamine will increase vascular permeability and vasodilatation. Vasodilatation and increased vascular permeability. Increase in vascular permeability will result into the thickness of the wall, increased thickness. Because of what mechanism? What is the effect of increased vascular permeability to the tissues? It will allow the exit of white blood cells. That is why mayroong mga white blood cells sa wall niyan, most likely, most of the time, mga eosinophils. So we will discuss later anong role ang gina-play ng eosinophils. Aside from allowing the exit of the leukocytes, what else will be allowed to leave the confines of the blood vessel walls, secondary to increased vascular permeability? Edema of fluid, water. That is why the wall will develop edema, further decreasing the diameter of the lumen. So, there are several mechanisms involved in the narrowing of the airways in asthma. Constriction, and then narrowing of the diameter secondary to edema, and then accumulation of mucus. The mucus glands and the goblet cells will be stimulated again by histamine to increase their secretions. And then, that should be the events leading into the acute phase of asthma. How about in late phase? Asthma. What is the predominant leukocyte that will play a significant role in the prolongation of the inflammation? Mayroong acute phase ng asthma, mayroong ding late phase, which is longer in duration than the acute phase. That long duration is secondary to the effects of the eosinophils. The eosinophils will also degranulate. And then, there will be prolongation of chronic inflammation because of the toxic chemicals that will be released by the eosinophils. Magkakaroon ng injury to the tissues of the airways, leading into the increase in the degree of inflammation. mai-enhance palalo yung increased vascular permeability. What particular chemical is released by using the fuels that will cause tissue injury? Ano? Very good, the major basic protein. So, yun ang story behind the development of narrowing of the airways in asthma. Okay, so that you will be able to appreciate the abnormality in our next slide, we will begin with the appearance of a regular or a normal alveoli. Okay? What epithelium is lining the alveoli? Simple squamous epithelium. Notice the average diameter of the alveolar spaces. So that is in low power magnification. Okay? Let us shift to this scanning objective. Magnification. So, yan ang usual size ng mga alveoli. How will you now describe the size of that alveolus? Okay? That is the usual size of the alveoli. How will you describe the size of those pointed alveoli? Including that one. Markedly dilated. The diagnosis of this slide should be emphysema. How will you describe the lungs in emphysema? Collapsed or hyperinflated? Hyperinflated. What is the mechanism behind the development of hyperinflation? Because of the dilatation of the alveoli. What is the cause of the dilatation of the alveoli? What will happen to the alveoli? To the wall of the alveoli in emphysema? Last grading period, pamanggot ang lands, no? What will happen to the wall of the alveoli in emphysema? Why will they become dilated? Because they will become destroyed. Diba? The development of emphysema is associated with what type of lifestyle? Smoking. Why will emphysema develop in smoking? Ano? The neutrophils and the macrophages will release ROS and their lytic enzymes. Those are the chemicals which will cause the destruction of the alveoli. Now, what will trigger the macrophages and the neutrophils to release those toxic chemicals? Remember, it is associated with smoking. So, madaming dust particles ang present sa smoke, aside from the harmful chemicals. Ang problem with the neutrophils and macrophages, they are both phagocytic cells. Before pa mag-close ang kanilang bunganga, nagre-release na sila ng lytic enzymes and reactive oxygen species. Kung anong destructive effects mayroon yung chemicals na yon sa mga microorganisms, same destructive effects will develop in the tissues of the body exposed to those chemicals. Kaya nagkakaroon ng destruction of the alveolar wall and nagkakaroon ng dilatation. Question. Lahat ba ng nag-smoke nagde-develop ng emphysema? Who among the smokers will develop emphysema eventually? What? Those who have alpha-1 antitrypsin deficiency. What role is played by alpha-1 antitrypsin in the prevention of the development of emphysema? Ano? Is that the correct term for the action exerted by alpha-1 antitrypsin? Etong mga enzymes, they are lytic enzymes. They will become neutralized by alpha-1 antitrypsin. They will become lysed by alpha-1 antitrypsin, which is also alpha-1 antitrypsin by nature is also an enzyme. It is also an enzyme which will degrade the lytic enzymes from the phagocytic cells. Now, saan minamanufacture ang alpha-1 antitrypsin? Okay, that will be your assignment. So, we will continue this discussion on Thursday. We will again have a quiz on Thursday. We have already discussed many slides, so prepare for a written exam or a practical quiz. Ay, bukas pala, no? Ayaw din yung madaming quiz. Madami kayong chances of, winning. The coverage of our quiz, next quiz will still be lungs. Kasi yun lang na-discuss natin. Okay, so let's have a quiz tomorrow.
Paper lang here. Next week na lang. Next week na lang. Week na yan.
Prepare it, prepare it for
Ay, nag-announce yun si Doc. Mag-quiz daw, ma.